So go ahead.
Recording.
Go ahead.
So, good morning to you all. Good morning, our teachers, senior colleagues, and colleagues. My name is Charles Donkoba, and I'll be taking question 3 of the April 2021 this question. My slide is not moving.
You might need to unshare again and share your screen, not the slide. Are you presenting from your laptop?
Yes, please. I'm presenting from my laptop.
So you share your screen, not the slide. Okay. Just stop sharing, then share again. So when you click on share screen, right? Still click on screen, not the slide.
Can you see my screen now?
Not yet. What is it telling you there? Okay, okay. You are sharing your slide, not your screen. It might still not move.
Try to unshare.
Maybe the recording should stop.
Yes.
Sorry.
Okay, now I guess.
Yes.
Yeah. So go
Sorry,
ahead.
sorry for the hitch. Yeah. So the question goes like, sorry.
Go on, please.
Yeah, so the question goes like this. Version 1, a middle-aged man with jaundice, leg swelling, and massive vomiting of blood. And then the version 2 says a 63-year-old who was taking cataflam for body pains, presented with hematemesis and melena. What is your diagnosis? What other questions would you want to ask? How will you investigate? How will you manage? When will you do an endoscopy? And what will you do during endoscopy? What is the definitive treatment? What are the possible sources of bleeding in this patient? What is the pathophysiology of the varices? Stroke, photosystemic anastomosis, and where are the various locations? What other drugs can you use as an initial treatment measure for variceal bleeding before endoscopic band ligation, apart from telepressin? And then the last question is, at what PCV level will you transfuse this patient? So the first question, what is your diagnosis? So for version 1, my diagnosis is massive upper GI bleeding, secondary to bleeding esophageal or gastric varices from a decompensated chronic liver disease. Because this is a patient who presented with jaundice, leg swelling, and vomiting. The jaundice and then the leg swelling suggests a possible underlying liver disease, possibly decompensated with the vomiting of blood. And then for the version 2, my diagnosis will be upper GI bleeding secondary to NSAID-induced gastropathy. This is somebody who presented with vomiting of blood and melena, and he had a history of cataflam use. Cataflam is diclofenac potassium, which is an NSAID. Question 2, what other questions would you want to ask? So since this person has presented with upper GI bleeding or vomiting of blood, I want to assess the degree of anemia. So I want to find out whether the patient has palpitations, dizziness, weakness, pre-syncope, or even syncope. And then also questions to actually establish the underlying cause of this upper GI bleeding. So for the best version, I want to ask, in addition to the massive upper GI bleeding, whether the patient has a history of melena, hematochezia, and whether there has been any previous episodes of such upper GI bleed. I also want to find out if the patient has abdominal swelling, which may suggest ascites, abdominal pain, fever, which may also suggest a possible spontaneous bacterial peritonitis, whether there is any history of sleep-wake cycle disturbances or personality changes, which may suggest hepatic encephalopathy. I also want to find out if there is a history of alcohol use, the quantity and the duration, history of IV drug use or sharing of shots, whether there has been any previous history of blood transfusion, history of multiple sexual partners. I also want to find out if the patient has actually been told that he has a liver disease or even viral hepatitis. And then for the second version, where the patient was using cataflam, I also want to find out whether he has had or he has been using this drug for a long time and possibly the estimated doses, any history of a gastric pain which is related to meals and heartburns, which may point to an underlying peptic ulcer disease, whether he has any history of early satiety, anorexia, or weight loss, which may point to a possible malignant transformation of the underlying cause. Now, the third question is, how will you investigate? In this patient, I want to do a full blood count. I'll be looking out for the HB, which is likely to be low because of the massive upper GI bleeding. I also want to look at the platelets, if he has thrombocytopenia, which may also contribute to the excessive bleeding that he has. I also want to look at the white cell count, whether there is any leukocytosis and the differentials, if there is neutrophilia, to suggest an associated infection. I want to group and cross-match blood and see if maybe about 2 to 3 pints of blood, seeing that he has massive upper GI bleeding. I want to do a liver function test, and I'll be looking out for the bilirubin levels. This patient has jaundice, so the bilirubin levels are likely to be elevated. I also want to look at the albumin level, likely to be reduced because of the underlying chronic liver disease. I want to look at the AST, ALT, likely to be elevated, and especially the AST to ALT ratio. If it's more than 2:1, likely a pointer to underlying cirrhosis. I want to do a clotting profile, looking at the PT, APTT. So INR in this case likely to be elevated because of the underlying chronic liver disease. I want to do a renal function test, so urea and creatinine. Urea likely to be elevated because of the massive bleeding and possible dehydration. Creatinine levels may also be elevated if there is AKI, which are supervened. I also want to look at the electrolytes. More likely, he may have low sodium levels because of the chronic liver disease, maybe with ascites, possibly from hemodilution. Then I want to do hepatitis B surface antigen, hepatitis C viral screen. Will help me, and as well as HIV screen, will help me narrow down an underlying cause. Seeing that he has a chronic liver disease, he may have hypoglycemia, so I want to assess his glucose level. And then I also do an abdominal ultrasound. I'll be looking for the size of the liver, whether it's shrunken or enlarged. I'll be looking for possible splenomegaly, if there is portal-like retention. And he may also have ascites, which the ultrasound correctly pick out. And when he's stable, I want to do an upper GI endoscopy. And at upper GI endoscopy, I'll really find out the cause of the bleeding, whether it's from varices or bleeding peptic ulcer, and intervene appropriately. Question 4, how will you manage? So this is likely to be an acute variceal hemorrhage, and it's a medical emergency. This requires a multidisciplinary team approach involving the emergency medicine physician, gastroenterologist, anesthetist, intensivist, hematologist, interventional radiologist. My goals of management to be control the hemorrhage. I want to reduce the risk of early rebleeding and also prevent bleeding-related complications such as infection, hepatic encephalopathy, acute kidney injury. So in terms of the actual management, I'll do a primary survey and looking out for any obstruction in the airway, And possibly, if he is unconscious, secure the airway by inserting an oropharyngeal airway or even intubating. Look at the respiration, if he's breathing well or not, especially the saturation. If the saturation is less than 94, give supplemental oxygen. And then the circulation, assess the pulse, the blood pressure, hydration status, whilst putting in 2 large bore cannulae to take blood samples for investigations. And then also starting IV crystalloids. So I will also pass an NG tube. The NG tube will help me assess ongoing bleeding in the stomach. The crystalloids, I will start with 1 liter of normal saline, maybe to run fast for about 30 to 45 minutes. And after that, I'll reassess. If the BP is still low, the patient is still in shock, I may have to repeat another 1 liter over the next 45 minutes to 1 hour. And thereafter, maybe set up a liter to run a bit more slowly, whilst working on blood to transfuse. If his HB is less than 7 grams per deciliter, I'll transfuse pure red blood cells. My target to be an HB of about 8. For those who may have an underlying condition which may require increased oxygen supply to the tissues, like those with ischemic heart disease, heart failure, I may want to transfuse up to a target of about 10 grams per deciliter. Otherwise, all other cases, my target to be 8 grams per deciliter. If the patient has low platelet less than 50, I would transfuse platelet concentrate, and then also give fresh frozen plasma if the INR is greater than 1.5, and cryoprecipitated fibrinogen levels are less than 1.5. I would also give IV vasopressors, so vasoactive agents like alipressin or triotide or somatostatin to help reduce the ongoing bleeding and reduce the portal pressures, and by extension also reduce the bleeding from the varices. I'll give prophylactic antibiotics, maybe ceftriaxone 1 gram daily for about 5 days, seeing that he's bleeding and that increases the protein load in the GIT, which may predispose him to secondary infection and a possible hepatic encephalopathy. And then I'll also monitor his vitals closely, check his pulse, check his BP, his urine output to assess whether my hydration or resuscitation is going on well or not. And like I said, once the patient is stabilized, as in has been adequately resuscitated, I would do an upper GI endoscopy for possible bowel ligation. If the patient does not respond to all these measures, especially the pharmacologic treatment and the endoscopic treatment, and there is ongoing bleeding, then I will employ balloon tamponade. So I can use a sense-taking Blakemore tube to buy me time for definitive treatment. In other cases, jugular intrahepatic portal systematic stent can be employed to actually reduce the ongoing bleeding. After the acute phase, I want to counsel this patient on the cause of the upper GI bleeding, and also continue prophylactic variceal band ligation and the use of non-selective beta blockers, and also treat any underlying causes. If, for example, the underlying pathology is chronic liver disease from chronic hepatitis B infection, I want to treat the chronic hepatitis B infection. When will you do an endoscopy? Sorry, it's obstructing my screen here. So when will you do? Sorry, something is obstructing my screen. So I think the question, let me quickly go back. So when will you do an endoscopy, and what will you do during endoscopy? Sorry about that. So I will do an endoscopy after this patient has been adequately resuscitated. That is, has received the necessary IV fluids, blood transfusion, and has also had a vasoactive agent, alipressin, for example, and prophylactic antibiotics. And I'll proceed to go and do an upper GI endoscopy. and this should be within 24 hours of the presentation of the patient. And during endoscopy, I'll do variceal band ligation. What is the definitive treatment? So for this patient who I think has decompensated chronic liver disease, the definitive treatment for him will be liver transplantation. Question 7, what are the possible sources of bleeding in this patient? So the possible sources of bleeding in this patient are bleeding from esophageal varices or from gastric varices, and possibly from rectal hemorrhoid as well, although we are not told whether he had atochezia. What is the pathophysiology of the varices or portosystemic anastomosis, and where are the various locations? So the pathophysiology is that for patients who have cirrhosis, like in this case, they have a distortion of their liver architecture, and this obstructs portal blood flow in the liver. In addition, there is increased vascular resistance from increased synthesis of endothelin, and also decreased production of nitric oxide, which is a vasodilator. So all these leading to or contributing to the obstruction of portal flow. This would lead to increased portal venous pressure and portal hypertension. Now, in an attempt to decompress the portal hypertension, there is diversion of blood through the portosystemic collaterals back to the heart. And this leads to engorgement of these collaterals, which produces the varices. So this diagram here, I don't know if you can see my screen. It's representing or giving us an idea of how the portal circulation goes on. So we have the splenic vein and then the gastric vein draining into the portal vein and then going through the liver. But once there is cirrhosis, there is an obstruction of the flow through the liver. So there is reversal of the flow. So reversal of the flow leads to engorgement or opening up of the collaterals and possible engorgement of these collaterals. So here, the gastroesophageal junction, you can have your esophageal and then gastric varices. What are the locations of the portosystemic collaterals? So the locations are the gastroesophageal junction here, which will lead to esophageal varices and then the gastric varices. Then at the splenorenal junction here, then at the rectum, which may lead to hemorrhoids. Then at the retroperitoneal area via the vein of Retsus, yeah. And then the umbilical and paraumbilical laterals, which may give you caput medusae. Then at the bare area of the liver, and then finally the omentum. What other drugs can you use as an initial treatment measure for variceal bleeding before endoscopic band ligation, apart from telepressin? So the other drugs that can be used are octreotide and somatostatin. Octreotide is actually an analog of somatostatin. Question 10, at what PCV level, what cell volume level will you transfuse this patient? So I'll transfuse this patient if the packed cell volume is less than 25%. My target packed cell volume will be between 25 and 30%. All right, so I want to just give a brief overview of variceal bleeding. So by way of introduction, gastroesophageal varices are present in up to about half of all patients with cirrhosis, and the severity of liver disease is a good predictor of their presence. The main risk factors for developing large varices are compensated disease, alcoholic cirrhosis, and the presence of red wheal marks at initial endoscopy. Acute variceal hemorrhage is a medical emergency, and it requires a coordinated MDT approach involving anesthetists, gastroenterologists, hematologists, interventional radiologists, and the priority is to assess and protect the airway, followed by an assessment of the respiratory and circulatory status. Resuscitation has to be initiated immediately to maintain the hemodynamic status of the patient until more definitive measures can be undertaken. Now, immediate goals of managing acute variceal hemorrhage are to control hemorrhage, reduce the risk of early rebleeding, usually within 5 days, and to prevent bleeding-related complications like AKI and hepatic encephalopathy. In terms of transfusion strategy, so in hemodynamically stable patients, transfusion of packed red blood cells should be restrictive. And the target is usually hematocrit or packed cell volume of 25 to 30%. Or if you are using HB, 8 grams per deciliter. Now, for those who adopt a more liberal approach and transfuse blood to a target of 9 to 11 grams per deciliter, this has been associated with increased mortality because such HB levels have been found to increase portal pressures and also lead to rebleeding. And current British guidance actually recommends platelet transfusion if the platelet levels is less than 50 times 10 raised to the power 9 per liter, and to give FFPs if INR is greater than 5. Bioprecipitative fibrinogen levels are less than 1.5. Currently, there is no evidence to support the use of tranexamic acid to control bleeding in such cases. In terms of pharmacologic therapy, it is generally safe to commence your pharmacological therapy, that is your vasopressors and antibiotics, straight away before you even organize an endoscopy. Non-selective beta blockers are not supposed to be used or started during the acute variceal bleeding phase. For patients who are already on beta blockers, when they present with bleeding, these agents have to be suspended. In terms of vasoactive drugs, so terlipressin, somatostatin, and octreotide are used for acute variceal hemorrhage, and they've been shown in studies to reduce all-cause mortality, also lower the transfusion requirements in such patients. Terlipressin, like octreotide and then somatostatin, they work by reducing the portal blood flow and hence the variceal pressure. Now, meta-analysis has shown that octreotide, somatostatin, and terlipressin are equally effective, and so any of these agents can actually be used. So terlipressin typically is commenced at the dose of 2 milligrams 6 hourly for about 24 to 72 hours, and actually can be extended to 5 days as soon as variceal bleeding is suspected. The use of antibiotics has also been shown clearly in studies to benefit such patients. It reduces the risk of bacterial infection as well as reducing early rebleeding. Current guidelines recommend routine antibiotics in all cases of acute variceal hemorrhage, regardless of the severity of the underlying liver disease. And the agents that can be used include the quinolones, so either you are using norfloxacin or ciprofloxacin, or the cephalosporins, especially ceftriaxone. And it is good practice to undertake a full septic screen as part of the initial workup in such cases. Now, an upper GI endoscopy should be performed.
Dr. Charles.
Hello.
Dr. Charles.
Yes, hello.
Can
you hear me?
Yes, I can hear you, please.
Thank you so much. Please, can you summarize time so that people can ask and so people can also interact quickly? Thank you so much.
Now, regarding the optimal timing for endoscopy, I must mention that yes, various guidelines suggest that this should be done within 12 hours of presentation, but studies have actually not shown any benefit comparing those who had urgent versus non-urgent endoscopy. And so it is recommended that this should be undertaken when the patient has been adequately resuscitated and is stable. So, to conclude, the cornerstone of preventing the first variceal bleed remains the use of non-selective beta blockers and variceal band ligation. And for acute variceal hemorrhage, a multidisciplinary approach markedly reduces mortality. And the mainstay of treatment for such cases is the use of antibiotics, vasoactive drugs, and then variceal band ligation. Thank you very much for your attention.
Okay, thank you, Dr. Charles, for your presentation. Okay, welcome contributions. Dr. Jamila, want to say something? Go ahead. Or Dr. Tanimu.
Thank you very much.
Dr. Jamila.
Good morning.
Hello, Dr. Jamila.
Yes,
wait,
please.
Wait a bit. You are a gastroenterologist. Let Dr. Tanimu say something first before you say.
Okay.
Thank you very much for this presentation. It is a good one. And for the second case of NSAID use, apart from asking about the doses or the doses, the duration, and all that ones, we have also to ask. We're supposed to also ask about why are they using the NSAID? Are they using it for joint pains or for other things? So that we dwell also on how to manage their problems of why they are using the drug. So that is it. And also, apart from the investigation for this number two, for this number one about the portal pressure, that is also in the investigation. Sometimes they used to tell us, I don't know whether the teaching have changed, the portal pressure, the normal around 10 to 12. If it is more than 15, it is increased a millimeter of water. So they use, I think in the school they used to tell us they use this one's Gans catheter or something like that to measure the portal pressure. But by and large, I also want to commend the organizers of this group, and also I saw that they have stopped forwarding the YouTube to the group WhatsApp, so that because it is easier when they forward it there, we just click and watch. Better than we have to go to the YouTube scout for it before we see. But by and large, it's a very good organization. Thank you very much for your effort. Thank you very much.
Yeah, thank you, Dr. Tanimo. Dr. Jamila, can you go ahead?
Okay. Thank you. Good morning, our teachers and colleagues. Thank you very much, Doctor, for the excellent presentation. Just to add, for the transfusion threshold, if you suspect variceal bleeding, is actually 7 grams per DL or a PCV of 21, and you stop once it's 9. So the range is 7 to 9 if you suspect variceal bleeding. And then the reason, like you rightly mentioned, is because if you liberally transfuse, you could increase the portal pressures and that could worsen the bleeding. Of course, the caveat there is if the patient is hemodynamically unstable, then you may actually go beyond that. So the threshold is actually, the target is between 7 to 9 grams per DL. Then also for the timing of endoscopy, we still work with 12 hours, except the patient is hemodynamically unstable. So once the patient is stable, then you can go ahead and do the endoscopy afterwards. But ideally, you should strive to scope the patients within 12 hours of presentation. Then for the second scenario, just to add for what you would do during endoscopy. So you would use your forest classification basically, to classify or to determine what your findings are. And depending on the findings, you could do your chemical approach, which is use of adrenaline injection, or you could use mechanical approaches like use of hemoclips, or thermal approaches like use of your coagulation diathermy. So usually it's depending on the severity, it's advocated to do a dual therapy instead of a single therapy. So if you have maybe from forest class 1 to 2A or 2B, you could do a dual therapy, and then 2C and 3, you could actually do 2C especially, you could just do a single therapy depending on what your further interrogation with a Doppler during endoscopy will find, because even if it's just a hemostatic spot, there could be a vessel underneath. So there are new modalities now during endoscopy that further investigate what is beneath the hematostatic spot. And then if you have an aberrant vessel there, or a vessel that is likely to bleed, you can actually use your hemoclips as well. Then, of course, for your clean-based ulcer, the bleeding rate is less than 5%, so you just continue your PPI therapies afterwards. Okay, thank you so much. It was an excellent presentation.
Okay, thank you, Dr. Jamila, for your contribution. Okay, so I'll read from the chat box. Dr. Success, thank you for the presentation. This patient is bleeding and may possibly have anemia. Would you want to give him IV fluid fast in 30 to 45 minutes? Dr. Oladeko He's saying, good morning. I think the diagnosis in the first scenario should have just been upper GI bleeding. There are no further information given to suggest CLD, or what are the information that supported your diagnosis in the first version or scenario? Concerning your line of investigation, I think you should have started with specific tests. For example, upper GI endoscopy. You listed upper GI endoscopy as number 5 on the list of your investigation. Okay, Dr. Ladekon, I think this scenario also gave us jaundice and leg swelling, so that will also may suggest CLD. Okay, and then for the endoscopy, Dr. Jamila just said endoscopy is not an emergency. It's an urgent procedure. So you have to resuscitate your patient first and make your patient stable before you do an endoscopy. Okay, Dr. Yusuf said that transfusion in upper GI bleeding is when PCV is less than 21%. Yeah, Dr. Jamila said so. Thanks so much for the beautiful presentation. Please, what is the NG tube for? Do you do lavage? Please, did you mention PPIs anywhere? Dr. Yahaya Mohammed said, thank you. Okay, for the clarification. Okay. All right. So, Dr. Charles, the NG tube.
Yes,
and,
Dr. Yeah.
And then
So
the PPIs and then IV fluid. Yes.
Okay, so starting with the IV fluids. So yes, whilst you are actually organizing for your blood, remember your blood may delay, but you can give your IV crystalloids, and this is critical to actually save the patient's life until your blood is available. And so use of IV crystalloids is not contraindicated in such a condition as a temporizing or holding measure. And then why upper GI endoscopy last? I think you have addressed it. That upper GI endoscopy in this case is not an emergency, but the patient has to be resuscitated adequately first. And of course, you need the HB level to decide what level of anemia you are dealing with and how to intervene before you send the patient to the endoscopy. Otherwise, your patient may actually die on the endoscopy table. And then why NG tube? So you pass an NG tube, one, to decompress the stomach. Number two, it also helps you to assess for ongoing bleeding. So from time to time, I mean, you can push in some fluid and aspirate and see whether there is fresh blood, and that may give you an indication whether the patient is still bleeding or not. And then PPIs. So I tried to answer the questions based on what was asked. So I mean, for the second, I think everything was pointing towards the version 1. So that is why I didn't mention PPIs here. But if we're dealing with version, sorry?
Go ahead, just go ahead.
Yes, so if we're dealing with version 2, definitely PPIs would have been indicated. So that is why I didn't really mention PPIs, because I focused on variceal bleeding. Thank you. I don't know if I've left out anything.
Yeah. So usually when somebody comes, no matter what you think, whether variceal, whether etc., usually when somebody comes with upper GI bleeding, you should give all the possible treatments, okay? Because you have not done an upper GI endoscopy. I think we answered this question earlier, and I mentioned that even in CLD patients, they also are prone to having, peptic ulcer disease. The fact that somebody has CLD doesn't prevent him from being having peptic ulcer disease, whether H. pylori associated, whether NSAID associated. So at the emergency, you see somebody with upper GI bleeding, you want to give all the you have to look at all the scenarios, and then you can give a PPI. So when you do an upper GI endoscopy and it's not suggestive of an ulcer erosions of that, you can now say, okay, you want to remove, the PPIs. But from the beginning, you should, because we have seen cases where some people come with that have, liver disease, chronic liver disease, diagnosed liver disease. We think the patient is having a variceal bleed, only for us to go into the do endoscopy and a huge a huge ulcer, is seen, okay, which is responsible for the bleeding. So it's not out of place. It's not out of place to give a PPI at the emergency while waiting for your upper GI endoscopy to make a definitive diagnosis, and then take, and then manage in line with that diagnosis.
Okay, that is well noted. Thank you.
Okay. So any other contributions, any other comments before we move to the next? I think we've trashed this.
Okay, Dr. Atta, just to mention just something about the NG tube. So it's actually controversial using NG tube to for lavage in patients with upper GI bleed. Most of the authorities believe that it's more useful if a patient is unconscious, maybe a patient in ICU, for instance, that is unconscious and you're not sure about the source of the bleeding, or maybe the patient is getting anemic, has not opened bowel for some time, and you're trying to find the source of the bleed. So you can actually do your lavage just to check if the patient, is having coffee ground granules or actually having blood in the stomach. So it's not routinely advocated for every patient that comes in with upper GI bleeding to have a gastric lavage. And then, like Dr. Atta has rightly said, in the emergency period, you can use your PPIs and the somatostatin analogs and telepressin, because you're not sure of the source of the bleeding. But once you have done your endoscopy and you've confirmed that an ulcer is not there or an erosion, you must stop it, because we know the other side effects of PPIs. And then also for erosions or ulcers, we know that PPIs are extremely important, because platelet function is upregulated in an alkaline medium. So once the PPIs reduce the pH of the stomach, that stabilizes the clots and also helps to prevent rebleeding.
Okay, yeah, thank you. So Jamila, so NG2.
Sorry, Dr. Jamila, now I'm getting more confused. You're saying if you do an endoscopy and you don't think it's an ulcer that's causing the problem, stop the PPIs. Yeah, you are saying that they are beneficial in stabilizing clot. Even if it's variceal bleeding, wouldn't it be beneficial?
Sir. No, sir. I just mentioned that so we know the advantage of PPIs in erosions or ulcers, why it's being advocated. Not that even if you see it in variceal, you should continue. Clearly, if you do an endoscopy and there is no ulcer or erosion, you stop the PPIs, because there is no indication and there is no benefit. If it's a variceal bleeding, you band and give your non-selective beta blockers and then treat the underlying cause of the liver disease, prepare for transplant. So that's clear cut for variceal. But if it's erosions or PUD, you have to continue with your PPI. So I just mentioned the benefits of the PPIs in that situation so that we remember why we're giving PPIs in erosions or ulcers, sir.
Okay, thank you. Then
Thank you, sir.
Clarify, I used to hear something about increased, is it gastrin production or something like that in people that have CLD? And that might be one of the indications for PPI also. So can you address that?
Okay, sir. So from the studies that were done, actually about 30% of patients with chronic liver disease have been found to also have coexisting peptic ulcer disease. And there are so many possible postulations. First is usually what is talked about is, they have portal hypertension. So the portal hypertension can interfere with the mucosal protective mechanisms and can predispose them to the ulcers. Then for those that have alcohol-related liver disease, the alcohol can also interfere with mucosal protective mechanisms. So for gastrin, I'm not so sure at this point. I may need to check, but for now, I don't know. I can't remember any theory that explains any reason why a CLD patients will have increased secretion of gastrin than the normal population, but my colleagues and seniors could help me clarify that.
All right, thank you.
Thank you, sir.
All right, thank you, Dr. Jamila, for the clarification and the contribution. Is there any other contributions before we move? The second presenter should share his or her screen. You can share your screen so that the second presenter will be able to
Hello, Ata. Dr. Ata.
Yeah.
Dr. Charles, thank you so much. Dr. Jamila, thank you so much. That was such a wonderful contribution. Thank you. I know our dear Chief Cookie will be so proud of our children. Chief Cookie, I don't know if you have any final words. I know your children have done so well. But I don't know if you want to say anything.
Good morning, everyone. Yeah,
Good morning,
so
ma'am.
good morning. Yeah, thank you so much. I mean, it was as you rightly said, it was a wonderful presentation, and there was little or nothing I have to add or fine tune. So I will just only talk about the use of PPIs in either variceal or non-variceal. PPIs, even though they are, life-saving drugs in terms of upper GI bleeding, you also have their, side effects. And because one of the roles of acid is to protect us against infections. So when you reduce the acidity of the stomach, the risk of bacterial translocation increases. And remember that the liver, one of the functions of the liver is that of phagocytosis. So when there is underlying chronic liver disease, and the liver is already failing, you don't want anything that would increase the risk of hepatic encephalopathy. So PPI is used at a large dose and for a long time in patients that have underlying variceal bleeding would increase the risk of hepatic encephalopathy. So that's why it's not advocated for them. But before in resuscitating a patient that comes with upper GI bleeding, you can use it. But usually when you are receiving such patients, as you are actively resuscitating, you are also taking a history. And if the history is suggesting a variceal bleed, and it's advocated that you can, not give the patient PPI. But if you have nothing to use and in an environment where somebody is, before you can get telepressin, it may even be so expensive. Instead of doing nothing, you can give the PPI. But if it is, that this is a variceal bleed, you should not give the PPI because you are going to increase the risk of hepatic encephalopathy because of, the bacterial load that would increase. So that's just what I wanted to add. Thank you.
All right, thank you very much, ma'am.
Okay, Chief.
So the next presenter.
Good morning, teachers,
morning.
colleagues. Doctor, can someone help me? I've been trying to enter with my laptop, but I'm not allowed, and I sent you a message.
Okay, send the message. I didn't get that message. Okay, so if you have difficulties, probably what we'll do is probably
Hello,
each
Dr.
presenter should post their presentation early in the morning, sir.
I think he's saying that he's been trying to log in with his laptop.
Yes.
But most likely, maybe because we don't know his name, he's in the waiting room and we can't allow him in because we don't know who it is.
Okay, I'm seeing 1 HP. Are you the one?
Yes.
Okay. So you are supposed to have typed your name when you wanted to come in so that we'll know who it is.
Exactly.
So maybe we should allow the HP to come in so that he can present.
I've allowed the HP to come in. So if you want to.
Okay. And then for others moving forward, you can drop your presentation in the mornings, even before the class, so that in case you start having difficulties, somebody can just easily start sharing. Not when you want to present, then we'll start asking you to drop your presentation on the group.
The presentation is in the group.
Is in the group?
Yeah.
Okay. When did you drop it? Okay.
Yesterday, I tested you.
Okay.
He dropped it this morning, past 6 also.
Oh, yesterday. Yeah, but can you share? Just share with your laptop. But you have to log out to one of your devices, please. So that
yes, I want to confirm that I can share with my laptops. I will now log out from this one.
Are you the one sharing now? This one is looking like from a phone, as if it's from a phone.
Are you the one
Not a-
sharing?
No, I think I can go with this one. Let me just log out then from the laptop.
Okay, it's okay. It's okay. Bye.
Let me log out from the laptop. So I'll be taking practice question for April. The question goes this way. A middle-aged man has a fever and cough for 5 days. He also has anosmia and dysgeusia. What are your differentials? Does the presence of anosmia and dysgeusia help you to narrow down your diagnosis? Why do elderly patients have a poor outcome? Discuss the relationship between hypertension, diabetes, asthma, and COVID. Mention the complications of COVID and discuss the pathophysiology of the complications. What are the controversies and your personal opinion about COVID vaccine? So the differentials, the same clinical features occurs to the respiratory tract. So it's most likely SARS-CoV-19 infection. It can also be upper respiratory tract infection, especially viral influenza respiratory syncytial virus. It can also be allergic rhinitis, atypical pneumonia, or hypersensitivity pneumonitis. Does the presence of anosmia and dysgeusia help you narrow down the differential? Yes. Most times, the anosmia and dysgeusia actually can be seen in association with COVID-19 infection, also in other viral infections, but it's most prominent in COVID-19 infection, and this because COVID-19 infection actually has trophism for the test buds, and also it also has its trophism and involvement of the substanticular cells. And these substanticular cells are actually supporting cells of the olfactory bulb. They disrupt neuronal signaling of the olfactory bulb, and then you have the anosmia. And then the invasion of the taste buds causes the dysgeusia that the patients have. So it's actually prominent in COVID-19 and present as the early features of COVID-19. So why do elderly patients have a poor outcome of this infective process? So it's actually a multifactorial cause. So we have waning of immunity in the elderly, which is termed immunosenescence, and you also have inflammatory aging, and there is also association with multiple comorbidities. So in terms of the waning of the immunity, there is actually a disruption in the innate and adaptive immunity in the elderly, and ideally when the body identify an infective or an antigen, what it does is to the immune system gets it recognized, and there is alertness to the antigen. There is destruction and then clearing, and this sequence of events are actually embedded in the elderly, and thus you have decreased immunity to fight the invading pathogen. And in terms of the inflammatory aging, when the body ages, there is a point where you have a arrest of the cell cycle, and this leads to apoptosis, and this apoptosis kind of causes a pro-inflammatory state in the body, and thus the elaboration of cytokines, which is more in the elderly, can also account for their poor prognosis of when infected with this pathogen. To ground it all, you have multiple comorbidities that are associated with worse outcome in COVID: hypertension, diabetes, coronary heart disease, which have also been shown to bring about the poor outcomes that aging has to do with COVID-19. So the relationship between hypertension, diabetes, asthma, and COVID-19 can be elaborated as such. So hypertension and diabetes tends to worsen the severity of COVID, and asthma has not been shown to have any clear-cut relationship between COVID and asthma. So in terms of hypertension, there is actually elaboration of, this is actually due to the disruption of the RAS and endothelin system, and this tends to upregulate the ACE receptor, and when it's upregulated, there is viral entry, worsening of the worsening of the COVID-19 infection. Actually, COVID itself has been shown to induce new onset hypertension in patients and also worsen the control of patients who have pre-existing hypertension, and overall they usually have poor outcome. In diabetes, there's also elaboration of DPP4 receptor, which though is actually more involved in MAS, which is a cousin to COVID-19 infection, but it has also been shown that COVID also have trophism for entry through that receptor, and it can worsen and increase viral replication in these patients. Another thing with diabetes is that the cytokine storm in COVID-19 causes a kind of hyperglycemic state, and this is actually induced by high load of glucocorticoids that are elaborated during this process. It tends to worsen glycemic control, and it tends to worsen the severity of COVID. There's not been clear-cut relationship between asthma severity or control and COVID. Just need to control them as the patient is used to. Mention the complications of COVID and discuss the pathophysiology of this complication. So the complications of COVID and the pathophysiology underlying it can actually be elaborated from the pathophysiology of COVID itself. And what happens in COVID is that the spike protein tends to have affinity for the ACE receptor. They have viral entry and then viral replication. With viral replication, there is increase in mature virus. With increase in mature virus, there is actually elaboration of pro-inflammatory cytokines. With elaboration of these pro-inflammatory cytokines that happens in this process, we have cytokine storm, and this would tend to disrupt the functioning of different organs. And this is because ACE receptors are elaborated in the epithelial cells of various organs. Notorious among them is the brain, the lungs, which is usually the point of entry. You have the brain, you have the kidney, you have the endothelial cells, have the GI system. So in the lungs, it will go affect the type 1 and type 2 alveoli system, cause disruption in the alveoli membrane. There is edema. This will progress to acute respiratory distress syndrome. There is respiratory failure. In the brain, you have it affecting the occasionally the brain parenchyma, causes damage to the endothelial system and the blood vessels, which will lead to stroke, thrombosis, encephalitis, affects the peripheral nerve system, can cause Guillain-Barré syndrome, affects the liver, viral invasion, and disruption of the functioning of the cells, which can lead to GI symptoms, affects the kidney. In this regard, it might cause destruction of the RAS system too, and worsening of kidney function. So affects the blood clotting pathways too, which can give rise to the disseminated intravascular coagulation that we see that is prominent in this infective states. So it can actually affect so many things in that manner. So what controversies and your personal opinion about this? So the controversies are actually these were actually chaired by the anti-vaccine, activist movements, and the message that they were trying to pass was that imposition of compulsory vaccination, which may have a legal and ethical twist to it. And they also suggested that there may be a spread of COVID vaccination and the 5G network that was then in vogue. And there was also antibodies from the vaccine, which they actually were spreading that it might strengthen COVID variants and then cause super spreading of the infective variants of this COVID to people around. There was also concern about alteration of human DNAs, which will worsen the infective state and cause more damage to the individual. So, but then there was also concerns of side effects that might be that arise from this vaccine, especially blood clot, myocarditis, and anaphylaxis. And then because of the imposition of these vaccines by the government, there was kind of mistrust by these organizations. There was kind of mistrust that was created in the minds of individuals about these vaccines because of the imposition that the government then had to do and make it compulsory for individuals to get the vaccine. But all in all, it was actually shown that my opinion about it was that it has been shown and it has been proven through scientific research that vaccination has actually decreased and reduced the severity of COVID-19 significantly, although it has also played a role in prevention of the disease. But in terms of reducing the severity of the COVID-19, it has actually been proven by so many research. And I think that we need to vaccinate as many people as possible for public and individual safety. So we've had COVID-19 lecture before. If it's still okay, I can go through it.
Okay. Okay. Probably, maybe, I don't know if we can just get contributions, but you can still leave the slides so that you can refer to the slides, because we have about less than 4 minutes to the end of today's session. So if we have any contributions or anything, so you can refer to your slides and probably give an answer. Okay. Dr. Tanimu, can you go ahead?
Okay. Thank you very much for this presentation. It's a nice one, an excellent one. And also pertaining why elderly people are at risk or have severe disease. Elderly people are amongst the group of people that have risk of the disease. They are more associated with the risk of disease. They are more found to be diabetic. So they are also more found to be hypertensive. So they have the common attribute associated with the infection and also severity of the disease. So this should be, I think, part of why they are more prone and why they have high risk of severity, tendency to severe disease. Thank you very much.
Thank you, Dr. Tanimu, for your contribution. Any other contribution? Any other comments or contribution? Our IDU specialist, is there anything new that you want to add?
So Tanimu is ID specialist. Dr. Ata?
Yeah, okay, yeah.
Tanimu is an ID. I know it's everywhere, it contributes in everything, but it's not specialty, it's IE specialist.
Okay, that's fine. All right, so I'll hand over to Dr. Christopher for final teachers.
So thank you, both presenters, the last presenter and the first one, Dr. Charles. Thank you so much. It was quite the first one was like an ignorant lecture. I know the question was, there were quite a lot of 10 questions, and so I must appreciate both of them for doing so much. And Dr. Jamila, thank you for coming in. Dr. Tanimu, I don't know if I can get all the names now, but thank you all. Thank you for making the class interactive and making it so rich. So I appreciate your efforts, really, we do. And I know the more you speak, the better you yourself will become once you go for this exam, no matter what is thrown at you, because you're used to speaking. Your first impulse is to speak. So once you start speaking, before you know, you'll be surprised, be amazed. Information will just keep pouring out. So it's congratulations, I would say. I want to encourage others that we're not hearing your voice. Please need to be hearing your voice. Need to be hearing your voices. Dr. Charles, I don't know your specialty, but we're not hearing your voice. So I know Dr. Ike is in neurology. So please, Dr. Ike, we need to be hearing your voice more. We need to be hearing it more. So thank you, everyone. Thank you. I have to respond to Dr. Tanimu's comment now. And before I do that, please, our presenters, participants, please let's be appreciating